Please welcome Neil Gesundheit. He's an associate professor of medicine in endocrinology, gerontology, and metabolism. That's what the cap page says. Associate dean for advising in the School of Medicine. Long list of teaching awards. He attended the first Obesity Summit. I remember him staying afterward for our session and actively participating in debating the NORC course. He brings a long-standing interest in public health consequences of obesity. He's interested, with Maya, who's our speaker after that, in launching an adult weight loss clinic at Stanford. So the second Obesity Summit will give him a chance to share his vision and insights with us. Please welcome Dr. Neil Gesundheit.
Thank you, Chris, and thank you for inviting us to this session. This will be really part of two parts. Next after me, Dr. Maya Artandi will talk about sort of some of the nuts and bolts of a potential medical weight loss clinic that we'd like to establish. And in a way, I think our view is that we'd like to give a medical counterpart and a medical face to the public of how Stanford can help with the obesity epidemic. I have a conflict of interest that I show here. We thought originally that we would be speaking early in the day, so perhaps a lot of these details are unnecessary, but still, just for completeness, we should probably go through where we stand in 2011 in terms of the prevalence and the consequences of obesity. By the NHANES study data that were published last year by Catherine Flagel, about a third of the US population, adult population, is obese, defined by a BMI of greater than 30 kilograms per meter square. And this is a little bit more in women than in men, but it's fairly symmetrical. What's not shown here is that this is an increasing epidemic, even more so in lower socioeconomic status Americans and Americans of color. So this is a particular epidemic in certain segments of the population as one of our major health disparities in the US. The other finding that I think is not new to this audience is that obesity is associated with increases in overall mortality from cardiovascular disease, cancer, diabetes, kidney diseases, and others. And I think most surprising to me when I looked at these data was when you look at NHANES data, and there was a study by Fontaine published several years ago where they extrapolated from NHANES and looked at mortality. So this is a bit of a stretch to go from NHANES data and try to determine how much of a change in population mortality there would be. But the estimates in that study, just to give you a sense about this, is that if your BMI is between 30 and 40, you lose somewhere between 1 and 6 years of life. And if you're extremely obese with a BMI of greater than 45, the estimates from that study are that you lose up to 13 years of life. So this is a problem on an individual level. It's a problem in the US on a population health level as well. And earlier, Dr. Engelman spoke about the health burden in terms of $75 billion a year in the US due to obesity. And I think the more recent analysis in JAMA last year estimated that the healthcare costs in the US are about $150 billion a year of excess health expenditures because of the obesity of the US population. And I don't think this slide is new to this group, particularly with the focus this morning on inflammation, but you can see that associated with increased weight gain are changes in a variety of cytokines and blood markers of disease and of inflammation. And this slide, taken from a presentation from Dr. George Bray and Lou Aroney, shows you with increasing fat stores what have been shown to be associated increased biomarkers with obesity. And you can see a whole host on the left-hand side of cytokines and then more conventional endocrine markers and other endocrine factors on the right-hand side of the slide. So there's a whole constellation of changes that occur with increasing fat mass. And along with that, we know that there's now an increasing risk of cardiovascular disease. There's an association with increased risk of hypertension, dyslipidemia. I'll show you in the next slide the effect on type 2 diabetes. So it's clearly having major health effects. Now, our point of view, if you think in a public health model, public health people like to think of upstream effects and downstream effects. So the downstream effects would be that if you are obese, you have hypertension, you have type 2 diabetes, you have dyslipidemia, you might have arthritis, you might have anything on that list, and that potentially would be a consequence downstream of being obese. The way we currently treat those disorders in the US is we say, oh, let's treat your hypertension with antihypertensives. Let's treat your lipid disorder with anti-lipid drugs, lipid-lowering drugs. Let's treat your diabetes with diabetes medications. When the true appropriate therapy is to move upstream and to say, what's the common factor that might be responsible for a lot of these abnormalities? Not in every case, but in many cases. And one of the common factors is clearly obesity as an upstream effect. Just to illustrate that, these data come from N. Haynes, and they show the relationship between obesity, shown on the x-axis here by BMI, and then the prevalence of type 2 diabetes from the N. Haynes study from 1999 through 2004 in that cohort. And what you can see is if you have a normal BMI with a BMI less than 25 versus someone whose BMI is greater than 40, that there's a 7-fold increase in the prevalence of type 2 diabetes as a function of the increasing BMI. And there's almost a step-like effect on that increased risk. So based on those studies and a variety of others, this is now 11 years ago when the NIH commissioned a multidisciplinary task force to look at obesity. One of the conclusions from the NIH consensus panel was shown here in orange, and that is that the initial goal of weight loss therapy is to reduce body weight by approximately 10% from baseline. And when this first came out, some people were surprised. Given how the American population has increased in its rate of obesity, the thought was 10% is a fairly modest change in the expectation, yet this is what the expert panel recommended. Now, to validate that conclusion from the expert panel, about 2 years after this conclusion, this is now about 9 years ago, the results of the NIH-funded diabetes prevention program came out. And what it showed were the following. If you look at the group that had intensive lifestyle intervention, shown in this plot, they showed that at about 1 year, they had a reduction of their weight by about 7%. These were overweight and obese adults with impaired glucose tolerance, but who did not yet have diabetes. And the goal of the study was to say you have biochemical evidence that you're on the pathway toward diabetes by having impaired glucose tolerance or abnormal glucose tolerance, but how many of you progress forward? And prospectively, they then randomized patients to the intensive lifestyle here, metformin or a placebo group. And what you can see was that with the intensive lifestyle intervention, at about 1 year, they were able to achieve a 7% weight loss, which was very nice. And that, at the end of 4 years, there was some return to normal, but they maintained about a 4% weight loss at 4 years. What you can see with that fairly modest reduction in weight, again, the NIH guideline was 10%. In this major study, they achieved the goal of somewhere between 4 to 7% with lifestyle intervention. But what you can see prospectively is that compared to the placebo group, who progressed such that about 40% of them had progressed to having biochemical evidence of diabetes, that in the group that was randomized to the intensive lifestyle, who had weight loss that was maintained, although modest, over the 4 years, that there was about a 58% reduction in progression to type 2 diabetes. So what this shows is that you don't have to lose a ton of weight. If you can reduce somewhere between 4 and 7%, or rounding it off between 5 to 10%, you can markedly decrease your risk of progressing to type 2 diabetes in this at-risk population. Now, if you look at more dramatic efforts to intervene, you can look at the Swedish obesity study. This was a study where, in Sweden, patients with obesity were randomized to either bariatric surgery or dietary lifestyle types of interventions. And what you can see is that in the group that was randomized to surgery, they had an average weight loss which was quite significant of about 16%. Their weight was more than that initially, but it stabilized after 8 to 10 years. And that associated with that was a 29% reduction in all-cause mortality, including a 48% reduction in myocardial infarction, heart attack, and a 38% reduction in mortality due to cancer. And as with the DPP, the Diabetes Prevention Program study, there was a marked reduction in the progression to type 2 diabetes over this 10-year follow-up of about 71%. Now, this is a more extreme intervention. These procedures are typically not reversible. They have morbidity associated with them, but it shows you that you can, either with modest weight loss through dietary means or more significant weight loss, you can achieve marked effects on your well-being and then potentially your mortality, your life expectancy. So this is one of the summary slides and really illustrates, I think, where we are in 2011. We have about a third of the population that is obese and about a third of the population, adult population in the US that's overweight. We have measures that have been fairly well established to achieve, at least in the short term, up to a year and potentially up to 3 to 4 years, somewhere between a 3 to 7% weight loss. And I think you saw this morning with several of the investigators, Michaela Kernan showed some data, Dr. Reven showed data, Dr. Tracy McLaughlin, and perhaps others, that we have ways we can use diet and exercise means to achieve weight loss of this magnitude of somewhere between 5 and 10%. But we have a gap in that patients are being referred to surgical procedures to try to achieve these more dramatic changes in weight, and there doesn't seem to be anything that's terribly effective sort of in this range. In the patients who would do very well to lose 10 to 15% of their weight perhaps in a fairly sustained manner and would be associated with significant improvements in weight. And the goal of our clinic, of a medical weight loss clinic, is to try to use a variety of means, dietary, counseling, group therapy, individualized therapy, potentially pharmacotherapy, to try to fill this treatment gap. The other part of the treatment gap that Dr. Artandi will refer to is not just the therapy gap, how do we get more effective therapies, but how do we get people who need treatment in to see their doctor to be treated by one of these different modalities. Right now the estimate is that of the many Americans, millions that are currently obese, probably only a few % are in the hands of physicians or other caregivers trying to seek treatment for their disorder. This shows you some of the potential promise with oral drug therapies. I've blinded the drug that is being used here just because it's not an approved therapy and don't want to lend any kind of potential commercial overtones to this presentation. But this was a paper published in Lancet with one of the newer therapies that is under current development. And what it shows is that at the mid dose and then at the higher doses, these patients with significant obesity are achieving quite significant weight loss that is sustained at least out to 1 year. In this arm of the study, these patients achieved about a 13% weight reduction. Again, now it's getting close to the level of weight loss you can see with lap band therapy at 1 year. So although these are newer therapies and not approved, there's promise somewhere down the road, down the horizon, that there may be other adjuncts to diet, exercise, behavioral therapy, that might be helpful to us in a medical weight loss clinic. So what's the Stanford remedy for the treatment gap, the gap that we're seeing in the current approach? The first is that we believe that you need a multidisciplinary clinic and approach to the problem, and that the real goal isn't to lose weight per se, it's to lose weight and to ameliorate the comorbidities that are associated with obesity. So if a patient comes to clinic and loses a modest amount of weight, but while doing so becomes normotensive, lowers their lipids to a favorable profile, changes other metabolic parameters such as CRP, C-reactive protein, again in a favorable direction, that they may meet their target without achieving a dramatic reduction in weight. It may be that only a 5 to 10% reduction would be sufficient to meet the medical goal in that patient if it's reversed a lot of their comorbidities. We believe another important component, something we haven't addressed today, is that the clinic and the providers have to have an empathetic approach to the patients. A lot of clinicians and the lay public places blame on the patient. The patient is at blame because they have poor self-control. They're at blame because they're too sedentary and they haven't made sufficient efforts to become more active. And while we agree that there need to be better efforts at self-control and with greater activity levels, many of these patients are just stuck. And a lot of their behaviors are somewhat fossilized, their eating patterns are fossilized, and there are strong biological motivators and biological drives to consume and maintain their weight at the level they are now. Many of these patients are not gaining weight, but they're at a greater level than they should be, and it's very difficult to move from that level. So we believe that you need to be empathetic and appreciate the need for this multidisciplinary approach. We think there needs to be extensive education about diet, exercise, and lifestyle. Some of these patients are simply naive about what is necessary to achieve weight loss and sustained weight loss. We need to attend to patients' psychological needs. We need to use a flexible, individualized approach where each patient is observed for the degree of excess weight, their comorbidities, and what the target would be to bring them back to a healthy weight level. And that, as part of that, we need psychological support and potentially effective therapies emerge, drug therapy for their disorder. Another important feature of our clinic is the understanding that weight gain is often slow and lifelong. Many patients have a pattern of weight gain where they gain weight, then they stabilize, and then they have another life event, and they gain weight, and then they stabilize. They have another life event, gain weight, and then before they know it, their BMI is well above 30, and they're having a really hard time trying to control their weight. And just as that may take place over many years, our approach is sort of, let's try to achieve 5 to 10% at a time. If we can get a 5 to 10% weight loss using a variety of modalities, and we can then maintain that over 6 months to a year, perhaps then it's time to try another cycle of 5 to 10% weight loss, much the way that they gained weight in these bursts over time. Let's see if they can lose weight similarly in decrements over time in a gradual manner. And then we acknowledged, and I know Dr. Morton would speak to this as well, that surgical approaches may be appropriate in patients where they're refractory to other modes of therapy or in severe cases. And as he would show if he were here, the surgical approaches have clearly been effective, but there are some significant side effects that can emerge. So let me stop at that point.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.